lectures. So we'll see what we can arrange for you all to, utilize before you all go to internship.
Okay, so good afternoon. I think it's the last lecture, so you may be tired, but we'll try to finish as early as possible. Like the last time, usually the last lecture of the course is for basic interpretation of ECGs by the internees. This is again a very important topic because when you start the internship by next month, you will be suddenly thrown into the deep end of the water, and people will ask what is there in ECG. So when we do the MBBS curriculum, we teach you about the ECGs, but at the end, we are mainly concentrating on some core ECGs, that is about 8 or 10 ECGs that every doctor, irrespective of whether you're a physician or a cardiologist or a surgeon, that you preferably should know to interpret. So during my talk here, I am going to concentrate on more on those ECGs. I will point out this is the ECG that you must know during your internship, because you may be the first person to see that ECG, and if you miss the abnormality, then we might lose the life of the patient. So, so I will show you those ECGs, but in addition, we will show you some other common ECG abnormalities as well. So I always say that ECG is like life, right? You have to have ups and downs like waves. Otherwise, if it is a straight line, that means you are dead. Now, before I show you some ECGs, we need to know the basics of ECG and various waves and the intervals. I'm sure we know these from your physiology days, but just to completeness of sake, I'll show you. There is a T wave, which indicates the depolarization of the atria, indicate the depolarization of the ventricle, and T wave indicates the depolarization of the ventricle. So these are the important waves that you should know, and in addition you have U wave, and some people say it is depolarization of papillary muscles, and there are other explanations as well, and also some important intervals. The end of the T wave and the RR interval, of course, from one R wave to the other R wave, and also the QRS width. Now, when we take ECG, we need, we call it 12-lead ECG, and there are 6 limb leads and 6 chest leads. However, we attach only 10 ECG leads. We attach 6 chest leads and also 4 limb leads. But when we generate the ECG, we generate 6 chest leads from the leads that we attach, and also we generate 6 waves, L1, L2, L3, AVR, AVL and AVF from the 4 limb leads that we attach. Now, one requirement is that we as junior doctors, you all should know how to do an ECG. That is why in the physiology and also during the professorals also, we want you to do ECGs on your patients. Because if you are posted to a faraway hospital and also in a place where there are no ECG. So please remember the way you do the ECG, and also the ECG machines may be different from place to place. So just play with your ECG machine when you start your internship and get to know about how to do an ECG, especially in an emergency. And also nowadays sometimes we might not be able to get everyone inside the wards. because of the ongoing epidemic, especially the COVID in the COVID unit. So you may be the person because not everyone will be able to go in there. So as you know, using the 4 limb leads, we generate 3 bipolar limb leads. Those are the lead 1, L1, L2 and L3. We use 2 limb, get both electrical generations and into one wave. And also we use unipolar leads, but we call them augmented limb leads, and then we generate AVR, AVL and AVF. So remember how you attach. I'm not going to go into details, but read a book and refresh your memory. I'm sure everyone has been taught about this, how to attach the leads and take an ECG the patient. Now that is about taking the ECG, but before interpreting, there are few important things that you have to do spontaneously. That is, have to pay some attention on patient identity. Now, even on the board, the ECGs may be filed in different patient notes. Because when these teachers come, they give different notes, and in boards usually they have an envelope, and when they take these ECG strips, they roll it and put it in those envelopes, and maybe wrong patient. And even when we see patients in the clinics and in the private sector, one simple question: you must be Mrs. Pereira or something like that, and you confirm that. Otherwise, you do a wrong diagnosis on a patient. And also, we need to pay attention on lead positioning. Sometimes,
recording in progress.
Be able to pick that up. And best thing to do is, if there is a suspicion, you do another ECG and compare with this, then you will identify that the previous ECG has been taken wrongly. And another thing is, I will show you an example, paper speed and the amplification. You know, sometimes people don't know much about taking ECG, especially when they come with ECGs taken in the private sector from these small dispensaries and clinics, and some trained people doing ECGs, they might end up not correcting the proper the paper speed and amplification. You know that proper ECG, usual standard ECG should have 25 millimeters per second paper speed and 1 millimeter per millivolt paper amplification, the electric amplification. And also sometimes there are many artifacts that were recorded at the time of ECG is taken. So you need to have some idea about the artifacts also, otherwise sometimes people get excited and scared and running to the hospital or to see a physician because of the same reason. So these are the 4 things that before looking at the ECG, before you try to interpret the ECG, that you have to pay attention to. Now look at this ECG. Because sometimes we train our eyes to diagnose certain rhythms. Now if you look at there are 2 panels. If you look at the atrial flutter that is in the upper row, you know that when you look at the ECG, this is a atrial flutter with 2 to 1 block. So we normally can identify this as a 2 to 1 block, because not only by counting the small squares or anything, but just because we have seen this and we have trained our eyes to identify. And also the second panel, the upper row, you know when you see that this is atrial fibrillation because it is irregularly irregular, and not only QRS complexes, the rhythm, even the QRS complexes are irregularly recorded. However, the same ECGs have been taken by slowing the paper speed. So making the paper speed faster. So 50 millimeters per second. And you see that characteristic rhythm pattern that we recognize has been lost. So I have seen sometimes, but easy way to identify this is by all these rhythms. Can you see that there is a box-like thing at the beginning? So that is for us to identify easily. So that indicates that width of that box indicates the paper speed, and the height of that box indicates the voltage. So by just looking at it, you know that this is a standard ECG, and the lower one, the width of the box is twice the normal. So we know that it is 50 millimeters per second. So keep an eye out. When you look at few ECGs like this, then it will come to your the way of looking at ECGs. You will be trained to look at these things automatically. So keep an eye on that. Now this is another ECG. Now at the end of the ECG, you see that box. You can see that it is a standard ECG. That is 10 millimeters per 10 millivolts and also 25 millimeters per second ECG. But sometimes you can see these very tall R waves in V4, V5 and sometimes in V6. So actually in V4 the QRS complex has gone above the paper, the ECG paper into this white area. So sometimes even smart ECG technicians, people who know a lot about them, they can purposefully reduce the voltage and take the same ECG to get these into the ECG paper. Now this commonly happens when they take these ECG strips, because otherwise the QRS complex go out of the paper. So you also should be smart enough to spot that. So that is why we should pay attention to the paper speed and the voltage. Now, what do you think about this ECG? Now this is a ECG that when I was doing my postgraduate training, this patient was sent to us for a ICD implantation, saying that this patient is having recurrent VT. But actually this is an artifact. How we identify it is, now when you take these ECGs, you can see these QRS complexes, 4 QRS complexes in the same line, L1, L2, L3 and L2 again, all are in the same line. And this is just one ECG complex. That is, this A4 size paper ECGs have several advantages. One disadvantage is that this ECG can record only 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12 ECG complexes only. But if you take a ECG strip, there will be about 40 or 50 ECG complexes, QRS complexes. Now, if you look at the V1, how come that L2 in the 4th row is normal and others are like VT? It can't happen because it's the same ECG complex. But if you very carefully look at it, you can see just above the QRS complexes of L2, these ECG the waves are the QRS waves, but in between are the artifacts. They are motion artifacts. The patient has moved. So I have several ECGs collected especially when you do ECGs on Parkinson's patients, especially people who have anxiety and excited, they develop a lot of these muscle tremors. As a result, you get these artifacts. So they are normal. So pay attention to artifacts also. Now, when you interpret an ECG, one important thing is for you to identify the heart rate. Oftentimes, the heart rate is printed on the ECG in that machine interpretation. I don't normally encourage young doctors to look at the machine interpretation because that is often wrong. These machine interpretations are there for the paramedics. Those in other countries there are volunteers who go in ambulances as a voluntary work. They are not health professionals. For them to read and contact the doctor, only these machine interpretations are there. But I normally look at the heart rate or ventricular rate that is printed. It is usually correct. But if it is not there, you should be able to calculate the heart rate by looking at an ECG. We know you can start from one QRS complex. You count how many large squares are there for a QRS complex. Now in here you have about 4, close to 4, little less than 4. So if there is one large square, the heart rate is 300. 2 large squares, the heart rate is 150. 3 large squares, the heart rate is 100. 5 is and 7 is 43 and so on. So if you know this, in many ECGs you can roughly calculate the heart rate. So at least I can tell you that this is little less than 4, but more than 3. It is between 175 and close to 75. So I would say this is about 8. Heart rate of about 8. So one thing that you need to know when you look at an ECG is to calculate the heart rate. This method is correct provided that the patient is in sinus rhythm and the heart rates are regular. The QRS complexes are regular. So many ECGs, the patients are on sinus rhythm and the heart rhythms are regular. So you can apply this method. But if the QRS complexes are irregular as in atrial fibrillation, then there are other methods to calculate the heart. I will show you when we go there. So this is the first learning point. Then we'll talk about the sinus rhythm. What are the ECGs that you can see in the sinus rhythm? Of course, normal ECG is in sinus rhythm, and that is characterized by having a P wave. Right? And that is why when you do a rhythm strip, you normally take L2 or V1 as the rhythm strip, because the P wave is best seen in L2 and V1. Of course, L1 and AV are but L2 or V1 are taken often because now this is another ECG you might see time to time. By looking at this ECG, or even when you examine the patient, you will find out that there is an irregularity in the pulse rate. The pulses are irregular. And even when you look at the ECG QRS complexes are irregular. But this patient is in sinus rhythm, and this is an ECG arrhythmia, which is a physiological condition or phenomenon. This is due to the increased heart rate during inspiration. So young people, young adults, they are or efficient, you can see the sinus arrhythmia. It's not a disease condition, it's a physiological phenomenon. Now this is sinus bradycardia. In a online presentation, I don't want to ask questions. I can see more than about 650 people are there, so no point in asking a question. But if you, the upper panel, if you look at what the heart rate is like, we call it sinus bradycardia because this is sinus rhythm. You can really clearly see a PR interval and also a constant PR interval, clear P wave. So this is a sinus rhythm. And if you look at the large waves, you can see 1, 2, 3, 4, 5, 6, 7, 8, and more than 8 is close to 9. So if you want to find out the heart rate of this patient, you divide 300 by the number of large waves. So if you divide 300 by 80, so how much it will be? It's less than 4, isn't it? Right? So this heart rate is in 30s. And you hear the heart rate is a little faster than that. Again, it's about 7 plus. So the heart rate is about 40. So this is sinus bradycardia. The heart rate should be less than 60 and the patient should be in sinus rhythm. The causes can be either eccentric or intrinsic. Usually they are extrinsic causes like hypothermia, hypothyroidism, and sometimes obstructive jaundice, raised intracranial pressure. And the commonest cause of sinus bradycardia is patients who are on rate control medication. It could be beta blockers, non-dihydropyridine type calcium channel blockers like verapamil or diltiazem, and also digoxin. And neurocardiogenic syncope and therapeutic sinus syndrome, they all can cause, they all are extrinsic causes. The intrinsic causes are the sick sinus syndrome, where the degenerative system, so the conduction system is degenerated, and also ischemic heart disease, either it's infarction or ischemia of SA node or the AV node. So these are the causes of sinus bradycardia. Sinus tachycardia is the opposite of that. The patient remains in the sinus rhythm, but the heart rate is more than 100. If you look at here, the QRS complexes are little more than 2. So heart less than 150 and more than 100. I would say it is about 130 in the main ECG. Above is also heart rate is about 130 and the patient is in sinus rhythm. So sinus tachycardia and sinus bradycardia as well as sinus arrhythmia are not pathological ECGs. They are physiological phenomena, but sometimes can be as secondary to the others. We can sometimes people develop sudden sinus tachycardia due to anxiety, pain, fever, various infections. When they have fever due to infection, acute LVF, pulmonary embolism, and hypovolemia. Chronic causes or the ongoing causes are during pregnancy, anemia, thyrotoxicosis, as well as hypokalemic excess. Now these days I see, even today I saw a couple of patients who have developed sinus tachycardia because of the anxiety. And you have to practically handle and make them understand that this is not a heart disease, but because of the way they think. Heart is an organ that responds very quickly to the things that you think. For the means due to the emotions. So these days people are very anxious because of this ongoing epidemic, and they often come to see us with breathing difficulties, palpitations, non-specific chest pains, and we find them having sinus tachycardia due to the anxiety. Now quickly, a couple of conditions that you might see often in the ECGs and important to diagnose if possible. One is LVH. Now remember, ventricular dilatation, it's either left ventricular dilatation or right ventricular dilatation, cannot be diagnosed by doing an ECG. We can diagnose atrial dilatation, left atrial dilatation and right atrial dilatation, which I am going to talk today. But we can diagnose the hypertrophy. Hypertrophy is not dilatation. Hypertrophy is increasing muscle mass and thickening the muscle wall. So when you have ventricular hypertrophy, how we identify is finding slightly widened and taller R waves in the V5 and V6 and as well as L1 and AVL. Also deep S waves in V1 and V2. So there are several criteria. One criteria is if the R wave is taller than 27 millimeters in V5 or V6, we can diagnose LVH, or else if we add the S wave in V1 or V2 to the R wave in V5 or V6, and if it is more than 35, it is LVH, or else if you take AVL alone, if the R wave is taller than 13 millimeters, it is LVH. So if you read the book, there are several criteria, there are several names given to these criteria like Sokolov criteria and so on. I'm not going to complicate the way you think and here, but if you are interested, you can read about it. But this is how you diagnose LVH: finding tall but slightly widened R waves in V5 and V6, and also deep S waves in V1 or V2. Now this is a real ECG of a LVH. You see that tall R waves in V5 and V6, and also deep S waves in V1 and V2, and here in V3 as well. And also together with the deep R waves, tall R waves, you also see this downsloping ST segment depression, as you can see in V5 and V6. So this downsloping ST segment depression is due to ventricular strain. Now, if you have only a tall R wave, that also could be due to very efficient electrical activity of the heart muscle. You can see tall R waves in thin people, in children, and because the leads are very close to the myocardium, you can generate a very tall, very high electrical stimulus. So that is not LVH, but to diagnose LVH, together with the electrical criteria I mentioned, that is tall R wave and deep S wave, you also have to have a repolarization criteria. That is what we call it, repolarization criteria for ventricular strain and S wave. Then the specificity of your diagnosis improves. The right ventricular hypertrophy is the other side of it. You find a tall R wave in V1. Now we know that in a normal ECG, the R wave is not there. There is no positive R wave in V1 in the normal ECG. But only few conditions give rise to that, and R wave, the right ventricular hypertrophy is one of them. So slightly widened QRS complex with a positive R wave, and also as you can see that downsloping ST segment depression there, that is due to right ventricular strain. Right ventricular strain. So as indicated in V1, to diagnose right ventricular hypertrophy, you should find upward or positive R wave in the V1 and followed by a down ST segment depression. Now this is a real ECG of right ventricular hypertrophy. As you can see in V1 and V2, usually in V1 and V2 the R waves are negative, and you only see a S wave, and there is no positive R wave, but here you find the R wave together with the downsloping ST segment depression.
Recording in progress.
Inferior posterior fascicle. But the right ventricle, right bundle branch goes to the right ventricle, and all these ultimately divide into form the Purkinje system. So when there is a block to the electrical conduction in the left bundle, you get the left bundle branch block. How you identify is that the wide QRS complexes and a positive and wide QRS complex in the V5, V6, L1 and AVA, and they are usually bifid, meaning that it is like there is a small division, as you can see here in the top of the QRS complex. So it is bifid QRS complexes. So, and also usually it is followed by ST segment depression. So all this is, now this ST segment depression can be seen as a ST elevation in V1 and V2. So this is how you get left bundle branch block. If you learn about how the conduction is spread to the left ventricle from the right bundle branch in a patient with left bundle branch block, you will understand how these ECG complexes are formed. Now this is the ECG of a left bundle branch block patient, and V1 and V5, L1 and AVL, you can see wide positive QRS complexes, and this is due to left bundle branch block. Now if you see a patient with left bundle branch block, please document that, because if they come with chest pain and having this ECG, we might wonder whether this patient has a new left bundle branch block and whether the patient needs thrombolysis. So this is a left bundle branch block. Likewise, if you see the same widen and bifid QRS complex in V1 and V2, you can diagnose right bundle branch block. So when it is in the lateral leads, you diagnose left bundle branch block. When it is in the V1 and V2, and again this is another reason for you to have a positive RBO, and you can diagnose right bundle branch block. This is an ECG, real ECG of right bundle branch block. Now the first positive deflection is very thin, but the second one is little wider. But it is a bifid, widen QRS complexes, positive QRS complex in V1, V2. So you can diagnose complete right bundle branch block. Why we call complete is when the QRS complexes are not so wide, we diagnose partial right bundle branch blocks. So usually the QRS complex is 0.04 or 40 milliseconds. When it is more than 140, we call it a widened QRS complex. Now, we talked about the heart rate measurement, and we talked about the LVH and RVH, and we talked about the left and the right bundle branch block, and let's go on to cardiac arrhythmias. Now, cardiac arrhythmias can be either bradyarrhythmias when there is an arrhythmia and the heart rate is less than 60, and also could be tachyarrhythmias when you have an arrhythmia with a heart rate of more than 100. Now, the important thing with arrhythmia is you can have an arrhythmia with no symptoms whatsoever. It can be completely asymptomatic, and the other spectrum, you can suddenly die. You can have a sudden cardiac arrest and sudden cardiac death. But in between, you can feel dizzy, you can have a lightheadedness, you can develop chest tightness, you can develop palpitation, you can go into heart failure, you can develop loss of consciousness, blackouts, and syncope. So in between, you can have several symptoms, but it could be asymptomatic as well as ended up in sudden cardiac death. Also, your symptoms depend on the underlying cardiac functions. Now, if your ejection fraction is poor, with the same ECG, the heart rate and the arrhythmia, you might suddenly go into severe symptoms and cardiogenic shock. But a young person with normal underlying heart functions might not feel that. Now, this is how arrhythmia can occur. That is why it is important to monitor do cardiac monitoring in acute cardiac conditions. This person was having normal sinus rhythm, but with a ST elevation suddenly has gone into ventricular arrhythmia. So we have to act quickly and DC cardio at this patient. If the patient has arrested, going to do a defibrillation. Now, out of the ECGs that I wanted you to know, these are some 4 very important ECGs, because as house officers, you all should know how to identify the ECGs of cardiac arrest. Because I have seen sometimes when I go in to see the patient, there is ventricular fibrillation on the monitor, and the house officer was trying to put a cannula in. Or trying to give some oxygen, where he has to quickly start cardiac massage and arrange defibrillation. So, ventricular fibrillation, look at the rhythm, always try to identify ventricular fibrillation. And asystole, pulseless ventricular tachycardia. It is nothing much different from a usual tachycardia. Only thing is the clinical manifestation, there is no pulse. So the patient technically has arrested. So the treatment is same as ventricular fibrillation. You have to start cardiac massage and quickly do defibrillation to divert the patient back to sinus rhythm. Pulseless electrical activity. Again, there are several pulseless electrical activity rhythms. So I have put 2 of them. Basically, ECG looks like normal, but you don't feel any pulses. So these are the 4 rhythms of cardiac arrest. Please don't miss them. They are important ECGs to recognize. If you miss them, you will never recover the patient. Now, if you look at the bradyarrhythmia, there are couple of bradyarrhythmia that you need to know. When the SA node is diseased, you get sick sinus syndrome. How it manifests is the rhythm looks normal as in the beginning of this ECG, but suddenly the SA node stops firing or stop generating impulses, and you get a pause. Now, if you look at this RR interval and see keyword complexes 1, 2, 3, 4, 5, 6, 7, 8, 10, 11, 12, 13, 14, 15, 16, 17, 18, 22. Now, when the 5 large squares is 1 second. When you have 22, then there are 4 to 5 second pause is there. So, about 4 to 5 seconds, the heart has not contracted, has not pumped any blood. And we see patients with 7-second pauses, 10 or 11-second pauses in reality. So when the heart is not contracted for 5 seconds or 7 seconds, the brain doesn't get blood, and you might ended up having a fainting episode. So that is how elderly people, this happens due to degeneration of the conduction system and the SA node, and usually in elderly, and they have a fall and they might ended up breaking their hip bones and so on. When there is a disease in the AV node, you get an AV block. So there are several types. I am not going to go into details. First degree AV block when the PR interval is prolonged, and second degree AV block when some of the P waves are not followed by QRS complexes, and when there is no connection between the atria and ventricles, when none of the P waves are followed by exactly by the QRS complexes, we call it complete AV block or the third degree AV block. I prefer the name AV block than the heart block because the patient gets scared when you tell patient that you have a heart block. The people who don't know about this get scared. So a common or a better term we use is AV not, an AV block. Now this is an ECG of a second degree AV block. As you can see, it's a 2-to-1 second degree AV block. Now I am not going to go into detail because I will not be able to finish in 1 hour. But there are 2 types of second degree AV blocks: Mobis type 1 and Mobis type 2. This is Mobis type 2, 2-to-1 AV block. One P wave is followed by the QRS complex, whereas the second P wave is not followed by QRS complex. And every second P wave is only followed by a QRS complex. So this is a second degree AV block. You should identify it's a bit of a stable AV block compared to the complete AV block. Now this is the complete AV block. As you can see, the P waves occur on their own. If you take out your divider, the dividers that we use in O-level, or else you can take a piece of paper and mark where the P waves are, and when you take the paper into the other place also, the P waves are in the same distance. And the QRS complexes are independent, but they also follow the same distance. Now if you feel pulse in a complete AV block patient, you will feel that the patient has bradycardia, that's very slow heart rate, but the heart rate is regular. Now, you might wonder what you should do in a patient with bradycardia. If you find that the patient has bradycardia, especially a bradyarrhythmia, sinus syndrome or AV block, first thing you should do is connect to the monitor, and sometimes just stopping the heart rate control drugs alone is enough if the patient is stable, and keep monitoring until the heart rate comes up. And we need to correct the electrolytes. And the medications we can try are atropine and give 0.6 milligrams IV as a bolus, setting up an isoprene infusion are sometimes helpful. So these are the things that you can do. Otherwise, you have to quickly find out someone who can put a temporary pacing wire, or else sometimes you have defibrillators where there is an external pacing facility. Then you can start external pacing. You can go up to about 40 minutes to 45 minutes doing external pacing until you find someone to pass up the temporary pacemaker wire. But if it is an ongoing problem, it's a chronic problem, we have to put a permanent pacemaker. That is the ultimate treatment for bradyarrhythmia when it is not reversible. Let's move on to tachyarrhythmias. Depending on the place where they originate, we can divide them into atrial tachyarrhythmias, nodal tachyarrhythmias, as well as ventricular tachyarrhythmias. And also sometimes we, for the purpose of easy interpretation, we divide them into narrow complex tachycardias and wide complex tachycardias. Now, narrow complex tachycardias are the atrial tachyarrhythmias and the nodal tachycardia. Now, atrial tachyarrhythmias originate from the atrial syncytium. You remember in the physiology days we learned that the heart is made of 2 syncytia. Those are the nets made by the cardiac myocytes. The cardiac myocytes are like Y-shaped structures. They divide in, and each can connect with a couple of other myocytes, so they form a net-like thing. We call it a syncytium. So, heart is made of atrial syncytium as well as ventricular syncytium, which is both are attached by a connective tissue cushion, which is electrical insulated. We call it AV cushion. So, when it is originated in the AV syncytium, we call it atrial tachyarrhythmia. tachyarrhythmias. The main atrial tachyarrhythmias are the atrial fibrillation, atrial flutter, and atrial tachycardia. Usually the etiologies are also common. The conditions that make atria to enlarge, like valvular conditions or obstruction, hypertension, ischemia, all this can cause. Now this is another ECG that you should be able to diagnose. You diagnose atrial fibrillation by finding these small fibrillatory rips in the upper panel. In the red arrow, it has pointed to the fibrillatory waves. We call it simple F waves, and also as compared to the purple arrow indicates a P wave. So this is the ECG of atrial fibrillation, where you can find irregular QRS complexes, not only irregular rhythm, but also irregular heights of the QRS complexes. So this is atrial fibrillation now in these ECGs you should be able to calculate the heart rate if it is not mentioned in the ECG. How we do is we take 15 large squares. So we can take from the beginning 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. Okay, we can take 30 large squares, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. So you count 30 large squares and you count how many QRS complexes are there in those 30 large squares. So here you have 1, 2, 3, 4, 5, 6, 7, 8. So you take 30 large squares and count how many QRS complexes are there in the 30 large squares, and you multiply that QRS number of those QRS by 10. So here the heart rate is about 80. If you want to be more accurate, you take 60 squares and multiply it by 5. But it is difficult. You take 30 large squares and count the QRS complexes inside it and multiply it by 10. So a couple of slides on how to manage atrial fibrillation quickly. We have a rate control option. We give rate control medication and warfarin to keep the blood and prevent the thrombosis, but give a rate control to keep the heart rate within the normal limits. Or else you can cardio and maintain the patient in sinus rhythm by giving an antiarrhythmic drug. You can either do a DC cardioversion or give something like amiodarone to cardio the patient and maintain the patient in. So there are studies that have compared the rate control strategy and the rhythm control strategy and found out that there is no mortality or symptom benefit of either of these strategies. So especially elderly people with underlying cardiac problems, pathological issues, pathological cardiac issues, best is to go for rate control. Young people and people who are symptomatic even after proper control of rate, then we go for rhythm control strategy. But the issue is we have to give antiarrhythmic medication, and those medications can cause a lot of side effects, including arrhythmias. And you all need to know the CHEDS2 score when you become a house officer, and to find out the atrial fibrillation patients who need anticoagulation. So you go by the CHEDS2 score. If the score is 0, they don't have to be on any anticoagulation. If the score is 1, we should give them aspirin. If the score is 2 or more, they should need warfarin. Now these are the ways that you do rate control and the rhythm control. The rate control medications are given, or else sometimes if it is difficult, the cardiac electrophysiologist can ablate the AV node. They can destroy the AV node and put a pacemaker. So whatever the rhythm the atria has, that doesn't transmit to the ventricles, because the ventricular rate is determined by the pacemaker rhythm. Rhythm control strategies, you can do amiodarone, sotalol or flecainide, or else now there is AF ablation. The cardiac electrophysiologists do, they ablate the atrial muscle, especially around the pulmonary origins of the pulmonary veins, and they ablate the rhythm. So I'm not going to go into details again, just highlighting what you can do. Anticoagulation is done by either aspirin, if the stat score is very small, or common one is warfarin, but now there are newer medications which are not available in the government sector, but you might see them time to time. They are expensive medications like Epigatran, Apixaban and Rivaroxaban. You might time to time see the patients who are on these medications. But if you know aspirin and warfarin and how to educate patients who are on warfarin and what to tell them and so on, you do it. Now, atrial flutter is also an atrial rhythm, but usually it originates around the tricuspid valve, and it always associates with some form of block. Now, in the atrial fibrillation, the atrial rate is about 380 to 400. Atrial flutter, the flutter rate is about 280 to 300. So, sometimes you can have a fixed block. You can get atrial flutter with 2 to 1 block, or 3 to 1 block, or 4 to 1 block. Or else, like in ECG, now the upper panel, here, this is a atrial flutter with a fixed block, which is a 3 to 1 block. Heart rate is exactly 100. The big ECG, in the lower panel, is atrial flutter with variable block. If you look at here, the heart rate is about 75 in the middle, but then you can have a heart rate of about 100 and so on. So it is a variable block, and whatever it is, the treatment is almost as equal to the atrial fibrillation. Now this is another ECG. Atrial flutter with 2 to 1 block, where the heart rate is exactly 50. It's a fixed block, atrial flutter with 50. Now the junctional tachycardia or AV nodal tachycardia, what actually happens is there is a slow pathway and a fast pathway in the AV node or adjacent to the AV node, like in these pictures. So the atrial impulses transmit to the ventricles via both these fast pathway and the slow path. But sometimes, if there is an ectopic cause, something like that happen, there can be a generation of a current. That means the impulses that come from slow pathway come little late and go up again in the fast pathway when the other impulses also come in the same way. And also it forms a current and make the heart to go fast. So this is the ECG of AV-NRT type, because there are two types. I am not going to detail again. AV-NRT type tachycardia or AV-RT type tachycardia. AV nodal re-entry tachycardia and AV re-entry tachycardia. They all usually happen in young people. The heart rates are very fast. It can be 180 or even 200. Now here the heart rate is more than 200. Heart is going very fast. And we have to do certain things and give certain medications to revert them back into the sinus rhythm. This is AV-RT tachycardia. How you identify is you will see an inverted P wave soon after the QRS complex. Usually the P wave is before the QRS complex, but AV-RT tachycardia, there is an inverted. Now in L5 you can very clearly see the inverted P wave after the QRS complex. But don't try to remember all these things. I just want you to know that there are atrial tachycardias, which is narrow complex tachycardia. There are nodal tachycardias, which is narrow complex tachycardia. Right? You also want to know that there are two types. One is AV-NRT and AV-RT. That's a different thing. Even if you don't know, nothing happens because the treatment is same. So the treatment, what we do is, we'll go in there. This is another type of re-entry tachycardia. but you will very easily identify this ECG where there is no P wave, either a very short P wave or totally absent P wave, but the QRS complex starts as soon as the P wave is over. So we call it early repolarization or delta wave. This is the ECG of Wpw syndrome. Again, happens for the same reason. There is an accessory pathway. So the impulses go to ventricles via both accessory pathway and the normal pathway, and sometimes there can be a start of a current or a re-entry tachycardia. So the acute management, we do various things. We do vagal maneuvers like therapeutic sinus massage, as you can see in the picture, or we can get the patient to do Valsalva maneuver. So I'm sure you must have seen these patients, and first try these non-pharmacological methods. Rarely they are successful. And then the two medicines that we need to know are the adenosine IV bolus. It's a fast bolus, but you have to check whether the patient has asthma and all that. And also you have to warn the patient about the side effects like flush. The verapamil is a very slow bolus. 5 to 10 milligram is given over 5 to 10 minutes. What we normally do is we give 5 milligrams over 5 minutes. After 10 to 15 minutes, if the patient is still in this rhythm, we repeat the dose over another 5 to 10 minutes. These AV tachycardia, AV junctional tachycardias are commonly known as supraventricular tachycardias as well. Now, the ventricular tachycardia is a very important rhythm because this is sometimes can deteriorate into ventricular fibrillation, because it is not like a supraventricular tachycardia. So narrow complex tachycardia, ventricular tachycardias can put you in cardiogenic shock, and also it can deteriorate into ventricular fibrillation, ended up in a cardiac arrest. And sometimes ventricular tachycardia per se can cause pulseless ventricular tachycardia, causing a cardiac arrest. But if the patient is hemodynamically stable, now same tachycardia, same ECG, one patient can come with minimum symptoms and patient is hemodynamically stable. Patient can say, I have some palpitations, I have some chest tightness, and the blood pressure is 130 by 80, and have ventricular tachycardia. Those patients, we can try the amiodarone or lignocaine, pharmacological methods to revert them back to normal rhythm. But some patients may be very symptomatic. They are drowsy, they are feeling lifeless and having palpitation, and the blood pressure is low, hemodynamically unstable. The blood pressure is 90 by 60. So those patients cannot wait for the medicines back. You have to do a DC cardioversion. Another person can present with a cardiac arrest. They don't have central pulses. So that is what we call as pulseless tachycardia. Same ECG, but in a different way. There you have to start CPR, and as quickly as possible you have to give a defibrillatory shock. Now this is ECG of multifocal ventricular tachycardia, a different type of tachycardia. You can see the QRS complexes or the abnormal waves as spindles. That is why they are called Tosaridi points. It is a type of ventricular tachycardia, and this is also, I want to tell you, this is not ventricular tachycardia. This is called idioventricular rhythm. Idioventricular rhythm is a wide complex rhythm. Usually heart rate is within the normal range, or sometimes there is a rhythm called accelerated idioventricular rhythm where the heart rate is about 110 or 120. But you need to know what this rhythm is. This is not ventricular tachycardia. This is not ventricular tachycardia. This is the rhythm that takes place when the ventricles are recovering from myocardial infarction. The ventricles have started generating electrical impulses to maintain their own rhythm. That is why it is called idioventricular rhythm. There is no impulses coming from atrium. So treating this rhythm is an issue. It can cause harm. So when you see this rhythm, don't try to control the heart rate. Because if you try to control the heart rate, the patient might end up having asystole. So know about idioventricular rhythm also and read about it. Now see, someone has taken this ECG without knowing that the patient has ventricular fibrillation. And you wouldn't do a 12-lead ECG in a ventricular fibrillation. As soon as you see this, you have to jump onto the chest and start cardiac massage and give a defibrillatory shock. But at least I have the ECG to show you. This is ventricular fibrillation. That is exactly how you identify VS. But as soon as you see this, don't take the ECG, but jump onto the chest and start CPR. I hope you all are conversant with CPR and ALS. So you will have to do it many times during your intention. Now, the next very important ECGs are the ECGs of ischemia. Now, I showed you imponity, I showed you ventricular tachycardia, I showed you, so those are all important ECGs. But here, non-STEMI or unstable angina is identified by these ST segment depletions, as indicated by the QRS. So these some of these arrows. ST elevation MI is identified by these ST elevation, but this is something you should never miss. Now this is the ECG without QRS complex for your comparison, but look at the V2, V3 and V4 and also V5. Look at the ST elevation. Please don't miss. And also by looking at the ECG, not only you will diagnose the ST elevation MI, you know exactly which part of the heart is being damaged. This is in this ECG is anterior septal septum and the anterior septal wall is getting damaged. And also you can guess which artery is occluded, which is important for the cardiologist when we do a primary angioplasty. This is another anterior ST elevation MI. We call it extensive anterior MI because V2, V3, V4, V5, V6, L1 and AVA, all the leads are both anterior septal wall and the anterior lateral wall are affected. So this is another anterior STEMI, extensive anterior STEMI. A big area of the anterior wall is affected. Now you should never miss this one. I don't know whether this patient survived. Huge ST elevation in V2, V3, so V1, V2, V3, V4, V5, V6, L1, AVA, and reciprocal changes in the inferior leads. So this is an extensive, massive infarction, maybe a clot in the left main or so. This is another anterior STEMI where we should not miss these ST elevations. Inferior ST elevation MI, you see ST elevation in the inferior leads L2, L3 and AVF. Finally, the other important thing that you can find out from the ECG is electrolytic abnormalities. You can find out evidence of hypokalemia, hyperkalemia, hypocalcemia, hypercalcemia, hypomagnesemia and hypermagnesemia. Out of that, the most important ones are the hypokalemia and the hyperkalemia. And that also there is no one particular ECG. Depending on the serum levels of that electrolyte, the ECG can change. Now see, in hypokalemia, with early changes, when the potassium is 2.8, ECG looks almost normal, but the QT interval gets prolonged, TVA becomes flattened when it is 2.5, and see what happened in 2 and 1.7. Likewise, hypokalemia also, when it is about 6.5, the QRS complex start widening, you will see a tall and tented T waves. But then slowly the QRS complex get widened, T wave get flattened, T wave also get flattened, and ended up in a sine wave pattern when the serum potassium is more than 90. Now this is a ECG of hyperkalemia. That's another very important ECG that you have to know, because in this ECG, as you can see, tall and tented T waves, especially in V2 and V3, V4 and V5. Look at those T waves, and the QRS complexes also have started widening. And you can't see much of T waves. So you should quickly identify this ECG as an ECG of hyperkalemia. Now if you see this, the first treatment that you should be doing giving calcium gluconate, IV bolus, and then look for causes and treat the hypokalemia accordingly. Okay, with that I'm going to stop there, and because it's extensive presentation, with a lot of things that we have to tell, but I wanted to finish as quickly as possible by showing these important ECGs. Thank you very much.
Right, sir, two questions to end up. How can we manage sinus node arrest?
Now, sinus node arrest, again, as a house officer, there's nothing much we can do. So, quickly put the patient on a bed, stick bed rest, connect the patient to a monitor, and try to, and also you look at the drug chart and stop all the medicines. But it takes time for the heart rate to come up. But in the meantime, try to give other medicines, like you can try atropine, which might not help, and also isoprene infusion, salbutamol, and also, but if these symptomatic causes are coming frequently, then we have to quickly think of getting a temporary pacemaker in until we arrange a permanent pacemaker implantation. And then I can see one question. Sir, could you please explain how to differentiate ST depressions in a non-STEMI and a reciprocal changes in a STEMI? Sometimes it's very difficult, but in a non-STEMI, what we normally see is either a flattened ST segment depression and or T inversion. But a similar sort of change can be seen in the as a reciprocal change also. But then what we will do is we look at the other leads of the ECG, and you will clearly see the ST elevation. So, but I have seen occasionally that the reciprocal changes are more prominent than the ST elevation, especially in the inferior infarction. There you see ST elevation of like 1 millimeter, but you can see a very clear reciprocal change. Sometimes it is difficult, but one clear answer is, when you look at the whole ECG, there should not be any ST elevation. So if there are no ST elevation, if you see only ST depression, that can be either non-STEMI or unstable angina. We collectively call it non-ST elevation acute coronary syndrome. But having said that, for both ST elevation and ST depression, there are multiple other causes. Now, for ST elevation, there are about 10 or 15 causes. I told a couple of them during the presentation. I told in this one branch block, aneurysms, early repolarization, Brugada syndrome. Likewise, there are about 10-50 causes. Likewise, for ST depression also, it's not only reciprocal change, there are several other causes as well. So you have to couple the clinical history and the evaluation of your clinical evaluation with the ECG to come to final diagnosis. Any other questions?
I think that's all, sir. Sir, can you please explain about Q waves and joint J point?
J point elevation. Now J point is where at the end of the QRS complex, where it meets the isoelectric line. So that is how we classically we diagnose ST elevation. When the J point is elevated, we call it the pathological ST elevation. The Q waves are formed. Now Q waves are there in normal ECGs also. Now even in if you take V5 and V6, we start with a very small S wave, R wave, and then a very small Q wave. But with this become pathological Q waves, they are more deeper and the depth can be varied from lead to lead, and also it is little wider than it should be. So then we call it a pathological Q wave. So again, when you keep looking at the ECGs, and you can't look at one place and make a diagnosis. If there are pathological Q waves in 2 or 3 adjacent or contiguous leads, you can assume that there had been a previous or old myocardial infarction. Sir, it is normal to get right bundle branch block in some people, yes, with normal hearts. Because the right bundle branch block is associated with certain congenital anomalies and also right heart enlargement and so on, we normally end up doing an echo just to exclude anatomical problems. But I have seen enough patients, it just has happened. Even young patients, they are all normal having functionally and structurally normal hearts. So in which lead I have so in which lead T-wave inversions are normal, and how it changes in children. Now, especially in females, in the anterior V1, V2, V3 can be normal, and of course in AVR it is always normal in normal ECGs. But in V1 to V3, now especially in females, a great percentage of T waves are inverted in V1, to a lesser percentage in V2, and even a lesser percentage in V3. Those are the usual T wave. Now it is like this. Now say there are about 500 people here, and we take 500 ECGs on all of us. And we see and we say that all ECGs are normal. But do you think that all the ECGs are identical? They are not identical. Therefore, when you keep reading ECGs, you get some experience. And that is why sometimes the patients come to us, and when they have gone to see their GP, they have said, okay, this ECG is not normal. You better see a cardiologist or a specialist. So when they come to see us, we have to explain them, okay, there are small things, but there can be a normal variant. So the T inversions are also like that. Sometimes T inversions can be normal in many people, and also sometimes tall people have T inversions. You go to the internet, put causes of T inversion, you can find so many normal causes. That is why sometimes we do an ECG when we lie down, and also standing up before we start the exercise ECG. Because sometimes T inversions get inverted when they stand. So to say the ST elevation or depression is significant, how much height there should be in elevation, then how much leads elevation should appear. I have seen some. Yeah, now you need to know. That is one of the major things that you need to know. The indications of thrombolysis. Now, to say that the ST elevation is significant, it has to be 2 millimeters or more in the chest leads and 1 millimeter or more in the inferior leads. Less than that is not an indication for thrombolysis. But still, you can admit the patient, observe the patient, and treat with inoxaparin. For ST depression, again, 1 millimeter, 2 millimeter depressions can be significant. Were there any missing questions?
I think that's all, sir. Yeah.
Now, the accessory pathway, what is the first choice of drug? Now, this treatment is doing an ablation because you can completely cure the condition, failing which we can give like verapamil. Now, junctional tachycardia, the drug of choice is verapamil. Okay, let's stop there, Roshan.
Okay, sir. Right. Thank you once again, Professor Nama Vijayasinghe, Professor of Medicine at KDU, for that in-depth analysis